Hello, everybody. It's an absolute privilege to be here again today with a fantastic, esteemed panel of experts and users and young nurses that is going to talk about brain injury recovery and rehabilitation. And the focus here is really about bridging the gap from hospital to home. And as a reminder, this is the second webinar on this topic, and this is all about our young nurses and midwives from across the world coming together to have conversations and hopefully submit some really exciting solutions about how we can take forward improved care and treatment for people that have suffered a brain injury from all over the world. So we're really excited about this global solution. It is our first Nightingale Challenge global solution, and we're all learning as we're going. But what we're finding here at Nursing Now with the Nightingale Challenge, working with Same You and other fantastic colleagues, which we've got with us today, is that we're finding lots of interconnections and lots of things that draw us together with that common purpose of really finding new and different ways that care better for people with a brain injury. So I'm now going to start to hand over to the people that are going to speak with us today. And as a reminder, each speaker will have about 10 or 15 minutes to talk about their topic, and then there will be an opportunity for questions and answers from the panel towards the end of the session. So please do put your questions and answers into the webinar so that we can have that opportunity to speak with you and answer any queries or ideas that you might have. So thank you all for joining us, and I'd now like to hand over to Jenny Clark, who is the Chief Executive Officer of Same You.
Thank you, Lisa. Thanks, everybody. It's an absolute delight and an honour to be here. Amelia and I are really, and the whole team at Same You, are really committed to doing whatever we can to support the growth of the careers of young nurses. We do that with such sincerity because of our own personal experiences, actually, 3 of them. We see that nurses are the key link for the patient, their families, their friends, and what's actually happened to them and why they are in acute care. So Amelia, as you may or may not know, had 2 brain hemorrhages when she was in her early 20s. And as you do know, hemorrhages and stroke and brain injury always come out of the blue completely. It's always a major trauma and shock. Now, I see that it's a trauma and a shock for families because you're moved into a place you'd never expected to be. You don't want to be there, you're frightened, you don't know what the outcome is. And wonderful nursing makes all the difference right from that immediate start when you get into A&E and then you get transferred to the ward. And then as your treatment begins, when you have something significant like a brain injury, it's very, very important for nurses to be a consistent red thread and a communication tool for the patients and the carers to be able to understand a bit more about from the clinician's point of view. Because while we have wonderful neurosurgeons, neurointerventionists and doctors, their time is very limited. And what we've seen is the nurses are the integral role for making sure that the fear factor and the information flow really works. So as we're talking specifically about brain injury recovery, just wanted to say why we wanted to start Same You. So Same You is now about 18 months old, so not very long at all. And we are still a very small charity, but our focus is very clearly only on how to make change in the brain injury rehabilitation pathways. Now, the way we see it, there's 3 major things that need to change. The first is that we have to create much more of an evidence base. And one of the things that we were astounded about when we started the charity was that there is very, very little evidence about neurorehabilitation and its efficacy and what works and what doesn't work. When there is evidence, it seems primarily from the information that I've got, and we work with UCL London, to say that it's about your physical disability and how intensive treatment can help your physical disability. But because that wasn't an issue for Amelia or for myself, we see that mental health and neuropsychology is a very, very underrepresented key component of recovery. You'll hear from great people later who are experts in this, but I just wanted to add our amateur patient, non-medical point of view. When Amelia had her first brain injury, it was in a wonderful hospital. She was treated in a wonderful hospital in central London. After she was discharged, after 3 weeks, having suffered aphasia, and obviously very frightened, and we were not clear what the impact and impairments she might be living with were going to be. She had a basic assessment. She was seen by nurses and clinicians, and she was given a test to see if she could make an omelette. And she was given a test to see if she could fundamentally read and write. And then we were given a questionnaire to see what help she would have at home and whether she'd be on her own or not. So first of all, she couldn't make an omelette before she had a brain injury, so that was a bit difficult. We obviously were looking after her as a close-knit family, and so we have been the people who actually helped her with her rehab, because there was no rehab on offer for her. And it took many months for us to realize that Amelia really did need some neuropsychology help to be able to get over the fact that she wasn't perhaps going to die the next day, and she wouldn't be suffering another brain hemorrhage. Sadly, she did have another brain hemorrhage 2 years later when she was in New York. And so we have another perspective. We have the understanding of what happens when you're seriously ill in the States, as well as what happens in the UK. So our understanding of what happens in the US is that it's very much treated with as another type of illness and you're given drugs. So when Amelia was discharged from her New York hospital, she'd had open head surgery, 2 strokes. It was very serious. And she was obviously in tremendous pain when she left. But the level of the drugs that they gave was incredibly high. So when she was a bit more understanding of what was going on, about 3 days after discharge, she got me to send them back to the hospital because they were so strong. And she managed just with her own self-will to get over the pain. Now, I'm not suggesting that's right for everybody, but I'm suggesting there is some gaps in the protocol that doesn't realize that or recognize the need for the neuropsychology piece. So I started saying that we think there's 3 things that's missing. Certainly the evidence base, and nothing will change until we get more evidence. The second is that when we started saying and we're trying to understand what was available and what the wonderful therapists that currently work in this area do, along with nurses, we saw that the treatments were evolving pretty much from individual interventions and experience. There's no real thrust that we can see, and we've now explored it for quite a while, that really is going to be almost a funding base, a catalyst for innovations and solution development to happen, as you would find in different organizations. So we think that's important. Innovations of care, evidence base, and thirdly, the workforce. So I think all I could say is to encourage you all to be encouraging other people you know in your network to start to think about neurorehabilitation as a major career path for nurses. We see that nurses could be the guide, the champion, could be the navigators through the pathway. And I think that there is a tremendous lack of therapists and nurses in this area. So I think my last point would be to talk about the challenge itself and say perhaps when you are thinking about what you might be coming up with as an answer, maybe that type of encouragement, something very simple to get a group of people, a community, to become more neuro nurses.
Thank you so much, Jenny. So all our young nurses and midwives that are online, I think some key messages there. It's innovation, it's about building evidence, it's about being truly holistic. So when you're developing your solutions and your ideas for this really exciting challenge, it strikes me that they seem to be really important elements to consider. Thanks so much, Jenny. We're now going to hand over to our next speaker, which is Professor Liz Lightbody, who is a reader in health services research at the University of Central Lancaster. Over to you, Liz.
I'd like to thank Nursing Now and Same You for inviting me to talk today. So within the presentation, I'm going to talk a lot about stroke research, but I think the concepts are transferable to other types of brain injury. I'm going to discuss funding challenges, but from the perspective of underpinning evidence for care, and discuss some nursing research that we've been doing as part of an NIHR global research group in India. And then finally, discuss some of the potential for technology enhanced solutions across the pathway, because that's part of my professorial position. So in terms of funding, there is more competition for scarce resources. It's not a bottomless pot, and we all do have to fight for the same resources available. And providers of care and those who commission services want to know that what they're providing or commissioning adds value, and that might be in terms of improved patient outcomes or patient experiences, or it might be in terms of working smarter and more efficiently. So in order to provide that evidence base, we need much more robust research, and that should be informed by the tacit knowledge obtained from the experiences of nurses in their daily practice. Because in order to produce change in clinical practice and knowledge, the evidence must be perceived as being useful. So our challenge is in creating knowledge that's useful, including commissioning and performing research that's highly relevant to nurses in their daily practice, and developing opportunities for nurses to create and share that tacit knowledge through things like action research groups. So the ideal solution is that all evidence is implemented into clinical practice in a timely manner, but we know that doesn't happen. Not all evidence is implemented at all. And we know that it generally takes somewhere between 15 to 20 years to get research evidence really embedded into practice, which is far too long. We need to recognise where the gaps are in our evidence within clinical practice and be working towards researching those gaps. And if we are giving nurses that opportunity to create and share their knowledge, the research should be relevant to nurses, but it also needs to be relevant to patients, carers, and the wider public. And if we do all of that, we will be providing the best care available to all patients. But if we always do what we've always done, we'll always get what we've always got. So we need to be really committed to improvement and making changes in the care that we provide and identifying the evidence gaps. But before we change practice, we need to know that the new is better than the old, and that requires research. So I'm just going to move on and talk a little bit about our NIHR Global Health Research Group Improving Stroke Care in India. The group has several different components. There's work streams around capacity building, but one particular work stream is around a research project which is nursing based. And we are looking at the feasibility and acceptability of introducing care bundles to staff, service users and their families. So the bundles were identified through stakeholder engagement. So we got nurses and clinicians together and asked them what the issues were in the care that they were delivering in India, and swallowing and hydration were one of the things that came up. The other things were in terms of neurological deterioration early following stroke, and the education and training of relatives and staff, relatives in acute stroke care, because in India, the relatives provide a lot of the hands-on care as well. But I'm only going to talk about swallowing and hydration today because of time. So one of the reasons why this was important is that we know the risk of pneumonia is very high if people have got swallowing problems. They stay in hospital longer, they have poorer outcomes, and ultimately they have reduced well-being. We know from the audit work that's been undertaken here in the UK that if there are delays in dysphagia screening, then that's associated with an increased risk of pneumonia. And the reduced delays in screening should actually be a focus for improving stroke care. So the general screening that's done is a water screening test. One of the very first bits of research that I ever undertook when I came into nursing research was around looking at water screening test for stroke, because it wasn't normal practice then. I'm glad to say that it is now embedded into clinical practice. But when you look at water screening test and compare it to like a radiological examination of the swallow, you'll find that about 56% of people who fail the swallow test could actually have normal food, and about 25% could have some kind of modified consistency. And it's also really important because normally when we do a water swallow test here in the UK, we refer people on to a speech and language therapist to have a more detailed assessment of their swallow test. And then they advise on the types of consistencies of food that people can have. In poor resourced areas, India being one of them, they don't have a speech and language therapist that they can refer on to for onward management. So it's really important that we are able to do something to help people take diet and fluids, because normally these patients are going home with an NG tube. So we look towards the International Dysphagia Diet Standardization Initiative, the IDSI initiative. This is an initiative that is looking at the different consistencies of food and fluids that people can have. And from that, we've developed a improvised swallow screening tool. So essentially what this does is it does some pre-screening to check that somebody can have a swallow assessment. And then we start patients off with a mildly thick consistency, because that's the easiest to swallow. And then depending on what people can actually, whether they pass or fail, depends on whether you test them on the next consistency. And then at the end, the nursing staff can record what consistencies patients are actually safe to swallow. Alongside that, we also developed management, intervention and instruction charts. These were culturally sensitive. So even within the different regions in India, people eat different foods. So what we did was we gave people an idea about how to test the consistencies of fluids using these visco sticks that we gave them to test the consistency of the fluid, but also gave them an idea about the foods within their region that meet that kind of consistency. Alongside that, we were also looking at doing some some tests that people could do at the bedside to test for hydration status and to see whether those in isolation or combination can actually accurately detect whether people are dehydrated or not. Because we know that about 1/3 of people are dehydrated within 24 hours of admission, and about 2/3 of people become dehydrated throughout their hospital stay. And that obviously affects outcome. But alongside the tests, what we also produced was what we call the osmolarity calculator app that the staff could use. And what this does is it allows people to input laboratory values around sodium, potassium, urea. You press the submit button, and then that gives them an idea about whether people are dehydrated. If they're dehydrated, it shows up red, at risk of dehydration, amber, and hydrated green. Also gives them an indication of how much fluid they should be having per day, and any abnormal values are in red. So that's just an indication of some of the types of technology that might be useful in, I guess, nursing assessments. So we know that information technology plays a key role in modern complex health care, and demands of stroke care could be mitigated to a degree by using some information technologies. They might be useful in reducing error rates, improving communication, assisting in diagnosis and monitoring. And technologies are already impacting our healthcare. We have developed a telemedicine toolkit that has been evaluated and developed as part of Cumbria and Lancashire Telestroke Network. It substantially increased the number of eligible and treated patients with the likes of thrombolysis across our 9 hospitals within the region. We've developed online training materials which have enhanced the training for stroke specialist nurses, making them advanced practitioners, and has allowed the nurses to actually, in some instances, take part in the telestroke rota. There's also been, this is something I noticed the other day, in terms of a cup that illuminates the entire body to tell you to drink more. Again, these kind of technologies could actually be used in acute stroke to try and keep people hydrated. But those technologies can be used right across the pathway and could make our care more efficient and cost efficient. So health monitoring in terms of blood pressure monitoring or oxygen saturation levels. There's healthcare delivery in terms of telestroke, which I've already talked about. There's artificial intelligence in terms of interpretive support. In the University of Central Lancashire at the moment, there's somebody who's developing a wearable device that can go in people's underwear to test how full their bladder is, so that you can encourage them to void before they become incontinent, which again would allow people to have potentially a bit more dignity in the management. But for research and health technology, it's essential that it meets the needs of providers and users. It also needs to be cost effective, but it needs to be evidence-based. And in order to do that, we need clinical trials. So as nurses, we are still developing an evidence base for our specific interventions, but we do need better methods to improve detection of complications. And that could be dehydration, it could be depression later on. We need more research on specifics of implementing evidence into practice. We are starting to develop the evidence base to inform decision making with a view to enhancing patient care and improving outcomes. But we still have very much more research to do. And what the take-home message I want you to have today is, today's research is tomorrow's care. Only by doing research will we attract more funding for the care that we provide and be able to show that it's beneficial and ultimately improve patient care. And that's why we're all here today, and that's why we're all nurses. Thank you.
Fantastic. Thank you so much, Liz. There's lots of comments going on in the chat that you'll look at later. I think that the impressive tools and documentation that you've demonstrated has really caught the eye of many of the people that's on our webinar, which I think is what this is all about. It's about sharing innovation, sharing evidence. But again, just for those that are thinking about their solutions, Liz's key message is we must build the evidence, and the whole point really of what we're doing is to reach out to trailblazer people like our nurses and midwives that are part of the Nightingale Challenge and this solution, to really think outside the box, to be brave, and because somebody's got to start building the evidence. It won't come out of fresh air. And I guess, and another time, people that have done research, like many of our panel members here today, can tell you the difficulty of that journey, but how important it is for somebody to start to ignite that new evidence that we can then, as Liz says, generate interest, create funding opportunities. But I think the other thing, Liz, that people need to think about too, that sparked in my mind, was the technology piece. Let's not underestimate the power of technology to create change. The teams, the importance of having multidisciplinary teams. And also the fundamentals of care are crucial. So something as simple as making sure people can get something tasty to eat, that they are hydrated. You know, let's not ever forget that those fundamentals are exactly, I think, you know, what's at the core of high quality nursing care. So thank you so much. I hope people have got lots of more food for thought there. And now we're going to go to our next esteemed colleague. Zoe, over to you. Thank you. Thank you so much for bearing with us all.
You're welcome. Thank you for inviting me. So my name's Zoe, and I am a clinical psychologist by background, but I work with my colleagues in nursing and I'm part of a multidisciplinary team that works in a community brain injury service in Wales for people living with acquired brain injury. And I also work in the university as well, and that job's very much about what we've been talking about not for it not to take 20 years to translate evidence into clinical practice. I guess the thing that really drew me to neuro rehab is when I started working in neuro rehab, and I remember the first person I worked with, and he used to be a miner. So he'd been made redundant when the mine shut, and he'd been working in factories. But I went to his house and I saw his mining lamp, and I saw the mining lamp of his father and his father before him. And this guy was in his 50s. He had a really strong work ethic. That's all he'd done. It was a narrative through the generations. And after he'd had his brain injury, or before, he was very much the head of his family. And after the brain injury, his wife at the beginning had to sort of take over, and she'd never really given the reins back by the time I'd seen him. So he felt like he'd lost his role in the family a bit. The head of the household role that he saw himself as having. He still felt like he had a lot to offer, but he had no opportunities to give that. He wasn't able to go back to work. He suffered from fatigue. As Jenny was saying, he didn't have very many physical problems. They were mostly cognitive. All of the training that I'd had was to try and help him psychologically, but it was all focused on trying to reduce depression and anxiety and trying to fix impairment and things like from physio, occupational therapy. And I guess I just ended up with a real sense that wasn't enough. So it wasn't enough to work with him so that he wasn't depressed, because not being depressed or anxious is not the same thing as feeling well, of having a sense of meaning and purpose in your life. And so I started to just think about models of healthcare. And the predominant model of healthcare in the NHS is the acute medical model, which, as we've seen in the last sort of 6 months, has obviously got an amazing role to play in healthcare. But I just wondered about the fit of just the medical model in terms of community healthcare. And so in terms of the medical model, the underpinning assumptions of the medical model is that people are passive recipients of care. You go to see an expert who does something to you, and you return to a pre-injury state. And there's also something about if the problem can be fixed, then you return to a happy person. And so none of those assumptions really work for people that are living with chronic conditions, because you can't take away that impairment. You can reduce it as much as possible, but ultimately the person's still living with some degree of difficulties that they have to come to terms with. And very often people are unable to return to their jobs, their relationships change, their roles in the families change. And so my question really was, are we still applying a medical model to chronic conditions? And when the healthcare service was founded 70 some years ago, the biggest burden on the health service were acute medical conditions. But in the last 10 years, the biggest burden on the health service now are chronic conditions. So there's been this transition in the population seeking medical care. And I think we've just inadvertently applied the same models. And so really the question for me is, how do we work differently for people with chronic conditions so we can meet the needs of the whole person, so we can help people think about things that really matter to them? So when I was talking to people about what do you want from neuro rehab, lots of people were saying to me, I want to feel like I can contribute to society again. I know I can't do that the way I used to, but now I feel like I'm on the scrap heap. I want to feel like I'm valued. I want to feel like life is meaningful, like I've got a reason to get up in the morning. And so these were the key things that we came across time and time again in our team. And we were just sort of thinking, can we do something a little bit more really to help people rebuild their lives? So I'm just going to share some slides with you to give you some examples of where we started, really, if I can share my screen. Okay. So this is us, the Jelly Babies. This was our team. And so we were asking the question, how do we design more effective, but also sustainable models of healthcare? Because resource is an issue. There was actually 4 of us working in the community brain injury service, covering the whole of the health board. And so we needed models to be more effective so that they meet the needs of the person, but we also need them to be sustainable. So we need to be able to deliver something sensible with the resource that we've actually got. And so we've got a lot of service users that are kind of saying they wanted to contribute. So we met with most of our caseload and we said, what are your unique skills? How can you, we've got a problem here. How can you help us build a better service for people? And so that was kind of using co-production. So already our team's now bigger. And then we linked in with our colleagues in the university and we said to them, how do you build models that promote well-being rather than just simply trying to reduce impairment? And so that led us on a journey to develop some theoretical frameworks about well-being. And I'm not going to bore you with the details, but I've put the references here. But essentially, when we were looking at models of what promotes well-being, we look at things like, this is Martin Seligman's PERMA model. He's kind of saying in order for people to experience well-being, they need to experience positive emotion, engagement, relationships, meaning and achievement. And I've written here how brain injury can strip all of those things away. So people don't have the opportunities to experience positive emotion. If they can't return to work or hobbies, experiences of engagement, meaning and achievement can be reduced. And we know that brain injury has a huge impact on relationships. So essentially the requirements of well-being are restricted for people with brain injuries. And so that made me think about, can we do some interventions to input some of these things again? And so when we developed our own sort of literature bases about what the components of well-being are, in addition to literature that already exists, and the only important thing here is we were coming up time and time again with key components for well-being are health behaviors, which we all know about: exercise, diet, nutrition, hydration. We've talked about these things, sleep. And we tend to just give people leaflets about these things and tell them what they need to do. But information, we know, is not transformation. And so we need to start thinking about how do we work with people with brain injury to support behavior change. And actually, one thing that I was astounded by was how important social connections are to health and well-being. So they support health and well-being to the equivalent of stopping smoking 15 cigarettes a day, and yet is completely ignored by the health service. And people with brain injuries and chronic conditions more generally actually are very socially isolated. So there's a lot of scope to think about social connections for people in brain injuries, both in terms of relationships and in terms of feeling connected to their communities. And then we were looking at psychological experiences. So we know negative experiences predict depression and anxiety, but we're not thinking in neuro rehab about giving people positive psychological experiences for joy, laughter, fun, which rehabilitation can be. So, and I'll just talk you through some of that now, but also well-being is not just an individual thing. We have to think about the communities people live in contribute to their well-being. And so we need to be thinking about healthy communities. So if you live in socially deprived areas, your opportunities for well-being are actually less. So, and then there's lots of interesting research coming out at the moment with the link between the environment and well-being. So spending time in nature and things that are really supportive for well-being, which again, we overlook when we think about interventions for people with brain injuries. And so this was some of the evidence that we started to publish. And then we were thinking about how do we translate this into clinical practice in less than 20 years? And so almost in the next 6 months, we started to develop interventions. We've basically changed the whole way our service works. So now it's built on promoting factors that contribute to well-being. We've built a group that people start with. Obviously, we deal with living with difficult emotions, but then we're talking to people about building their strengths, and not as a token gesture, but what strengths remain and how can we build on that. Helping people think about meaning and purpose and getting a sense of direction, because people often report to us that they feel lost. that they were heading somewhere. This has happened and the rug's been pulled from under them and they don't have a sense of direction. So we help people try and get a sense of direction for them. And then we help people translate some of those ideas into action, thinking about behavior change. Then we talk about the importance of positive emotions, the relationship between physical health and mental health, and then talking about maintaining behavior change. So at the moment, we're still in the remit of the health service, but what we really need to do is help people integrate into the health service. So when I was talking about my minor person earlier, I wanted him to have a meaningful role in the community where he could contribute something. And so lots of the patients we see tend to be younger men, and some of the younger men that we see from the socially deprived communities in Wales don't really want to talk to me about their feelings for an hour a week, nor do they want to speak to our nurse about their feelings for an hour a week. So we had to develop something to help them engage better. And so what we thought we'd do is link in with projects in the community, nothing to do with brain injury, and work with them to establish a neuro rehab project that we deliver from the community, and when we pull out, they remain there. So I'll just come on to some of those things in a minute. For people that are interested in the group I described, there's some references here. This is a qualitative review we've published. Also, we're now starting to run a randomized control trial of that wellbeing intervention. It's just on hold because of COVID. So this is, again, using the evidence base to inform an intervention and then evaluating that intervention in the best ways that we can. We talked a little bit about technology, which is great, because I just wanted to tell you about another kind of idea that might feel useful to you. One of the problems that we've got in brain injury is that people use technology like their iPhones, their iPads, but they don't use assistive technology even when it can be really helpful for them. So even though sometimes products exist on the market, it's not being translated into everyday life for people with brain injuries. And so we wanted to look at some of the reasons for that, because if we could help people to use assistive technology, we could reduce the burden on the health service, but we could help people be more independent and participate more in things. And so we've published a review about the barriers for people with brain injury using assistive technology, but we also started a project where one of the reasons that when technology sells well, like the iPhone, is because it's designed by people like us so it's designed by middle-aged people with a disposable income that know what they want, and then that demographic tends to be the demographic that buys it. So there's a link between the designer and the end user. In assistive technology, that link doesn't exist because the designer is nowhere near on the same page as the end user. So we end up designing lots of products for people with brain injuries, and it just ends up being abandoned. So one of the interesting things that we've done is we've been working with people with computer science, and we've asked people with brain injuries to describe sort of day-to-day problems they have. And then together we've helped them come up with a solution for that that's bespoke to them. So one person couldn't get on with their electronic pill dispenser that was off the shelf because he said it was like a spaceship, and he's not sitting by it every minute of the day. And so he kept forgetting to take his medication. He was having seizures. So in this project, he's learned to build himself using 3D printers a tray of seven capsules. He puts his tablets in, and then he can take the tray with him when he goes out. And then when the tray is removed from the device, it texts him and reminds him to take his medication. It also texts him to say, put the thing back in the box when you come home, and refill it. So that's just an example of something that we hope to build, where we can increase the usage of assistive technology by involving the person with the injury. And here's a paper you can read about that. Another project that we've kind of developed again about trying to integrate people into the community was we worked with a company called Down to Earth. So they're nothing to do with brain injury. They're about sustainable building and teaching the community about sustainable building. And because we had lots of young people, that liked building but didn't like to discuss their emotions with psychologists and nursing. We wondered if we could engage them in a building project. And this is what they've built together, all by hand, no machinery. We took them to the Gower for a day a week, down to earth, taught them how to build. We taught them the skills for sustainable building. And we went there too, and we talked about their emotions live on site. And so we delivered all of the kinds of therapies we deliver in the hospital. We put all of the memory aids and compensatory strategies in, but in this setting. Another kind of example is where we ran an adjustment group for people, but we used photography to help them talk about complicated issues like identity change and adjustment. And at the end of that, we put on some photograph exhibitions with an artist in town, and the patients put on these exhibitions to tell people about the hidden disability, to try and educate the public. But in as well as contributing to psychological therapies, it gave people a sense of meaning, that they were helping their peers by educating the public about brain injury, and it gave people a sense of achievement and something to work to. So this is an absolutely free project. I love it. There's a construction company in Swansea that are just a bog standard construction company who renovate houses and sell them on. And they've kept a house free for some of our patients. And we take them there with our occupational therapists and our nurses. And they get taught skills in plastering, they get certificates in bricklaying. And that helps them bridge the gap then if they want to return to work. They get references from it. So the MySpace are kind of saying, okay, it takes longer to renovate this house, but we really get a sense that we're giving back to the community. We understand brain injury a lot better, and we're invested in doing this for you for the foreseeable future. And then we also work with the Swans Football Club, and they come in and we get footballers and celebrities to teach our patients about health, nutrition, which comes a lot better from them, but it helps them. We get free football tickets for them to go to the football, but also we've started gym clubs with other patients so people can exercise together. And you can see some of the pictures here. This is actually the land behind the hospital, which we've renovated with polytunnels, so we can grow our own fruit. And I guess the main thing to say is what we're trying to do is help people integrate into the community by bringing the health service and the community together. So patients have got meaningful roles afterwards. So when we discharge people, we're discharging them to a meaningful, purposeful life. What we were trying to do is create a bridge between the health service and the community. I think what we've actually done is created a community of people with brain injuries. And I don't know if any of you saw some of the flash mob stuff that we did with Same You in the Welsh Government. But that was an example of, we just asked some people if they would help raise awareness of brain injury, and we ended up having about 200 people come to that flash mob because they're part of a community. So we just needed to ask one or two who involved other people. And so now we really do have a sense of having reduced social isolation for people and giving people meaningful roles. Again, this is another project where we take people surfing. I'm going to end because I'm just coming over my time, but I just wanted to give you one quote from this, where this has ended up being a real psychological therapy group, because we have to do a lot of work to get people surfing. But we had one person who was 18 and he had profound physical as well as cognitive problems. It took us ages to convince him to give surfing a go. But when there was a moment where he was on the board looking into the sea, and he was like, I thought my life was over after this brain injury. If I can do this, what else can I do? And that was so powerful. I never thought that I would be a psychologist delivering mindfulness interventions on a surfboard, but why not? Because there's so much laughter in that group that it just occurs to me that if we can make a difficult task of neuro rehab enjoyable for people at times, then we should. So my main point is it started with 5 of us, not very many resources. We ended up linking up with people in the community and our service users. We developed a coherent theoretical model of well-being, and now we've got this many people working on something that 5 of us used to work on. And so I've kind of tried to talk about some of this work in a recent book chapter we've just published. So there's a reference here, and I'll share the slides at the end. And that's it from me. Thank you very much for listening.
Oh my goodness, Zoe. Well, thank you very much for sharing that yet another superb presentation. I don't know where to start or finish. I'm quite emotional because I think sometimes maybe we need a little bit of reminding the difference we do and can make to people's lives. And I think when you mentioned that idea about helping people to rebuild themselves, that just really struck a chord with me about the power that we potentially have to make a difference if we utilise ourselves, the evidence, be creative and innovative like yourself. But I think the other thing as well for people to reflect upon is the concept of well-being, and how really, and we've had some chats in the box with Helen around a garden she's created for patients that she's cared for, how well-being can unite us all. It can unite us all, whether we're a clinician or whether we're a patient or whether we're in recovery. And it's something we all need, isn't it? So when you were looking at what people needed post a brain injury, we all need to try and find ways to eat well, live well, get good sleep. And so it's a real opportunity, I think, well-being, to be a real connector between the professionals and the patients and the clients moving forward. So thank you so much, Zoe, and I'm sure I can tell just by the feedback, you've inspired so many people, but you're a tough act to follow in terms of coming up with some solutions. But I'm sure that there's lots of food for thought now buzzing around our participants' minds about what they might do. And I guess the other thing people on the webinar to also think about is, Zoe, how you've reached out to different people. So whether it be housing, you haven't just kept within a health bubble, have you? You've really, broadened yourself and broadened your mind and the team that you've worked with to think outside of traditional health services. So engaging within sport and football and all of the things that you mentioned. So just think about that too, colleagues on the webinar. It's not just about talking to people in health. I think you need to go wider to do something really, really transformational like we've just seen. A real privilege. Thanks so much, Zoe. So I don't know whether we've got Kat, but if not, let's go to our next speaker. Have we got Kat? I can see you, Kat. Can you speak? Have we got Kat? It's so strange that we've got this challenge at the moment.
Kat, can you hear us? Hang on, let's unmute.
Do you want to see if Kat wants to talk? And even if she can't hear us,
I think we can. Kat, can you hear us? You can't hear us.
Oh dear, that's such a shame, because another inspirational practitioner. Maybe Kat will have to get a voiceover of what you were going to tell us and share that on the site for people, because your work is incredibly powerful and inspiring as well. So unfortunately we don't seem to be able to get Kat. So now we go to Manashi, who is our, as I said earlier, one of our Nursing Now Young Nurse board members, and has been a fantastic champion that promotes young nurses and midwives all across the world. So over to you, Manashi.
Sure. Thank you so much, Lisa. And really as well, thank you so much to Zoe as well for sharing and her presentation. Because I think it also really talks a lot about, like she was saying, moving beyond having patients coming from brain injury, just living, and moving into well-being and being able to look at what are the solutions towards that. And I was really amazed at all the solutions that they have managed to come together and put together, being able to come up with those solutions for patients. So that was really amazing. And yes, so today I'm going to be talking about brain injury rehabilitation in Zimbabwe, where I'm from. And really, in Zimbabwe, we see a lot of patients that do need brain injury rehabilitation. And as Prof. Liz was sharing as well, we see a lot of patients that really have a lot of stroke conditions. And what we find is really the hospital environment provides an environment of safety for patients. And upon being discharged, there really is a lot of fear that comes up as to what exactly patients are going to be able to do once at home and how families are going to cope. So there really needs a lot of support towards that, and really looking at how to support patients coming from the hospital, the safe hospital environment, and moving back into the community, how to be able to support them. So in Zimbabwe, we have community rehabilitation centers usually, where patients coming from hospital can be able to move into this community rehabilitation center, which is sort of like a midway level between the hospital and the community and home. But it more or less is still a safe environment. The challenge with some of these community rehabilitation centers is patients and families have to, a lot of the times, have to pay to be able to get their relatives admitted into these centers, which poses a challenge to a lot of families who are not able to actually pay and raise funding to be able to get into these centers. So what we end up finding is some families end up bypassing the community rehabilitation centers and just getting their relatives and families discharged straight from hospital directly to home. I think this provides a lot of opportunities for nursing in looking at how to be able to reach out to those patients that are at home, and being able to look at what are some of the opportunities in being able to do that. I was really amazed in terms of solutions, particularly in health technologies, and being able to look at how we can be able to monitor patients at home, being able to do oxygen saturations, blood pressures, and being able to have nurses reach out to those patients that are within their communities. So it's really amazing that all the work that is being done, and all the work that is being shared, particularly through this platform.
Fantastic, Manashi, as ever. Thank you so much. And it's always great to hear from an early career nurse about how they're trying to make a difference. So thank you so much for that. And I think now we're handing over to Q&As, which I'm really keen. I think we did have some questions in the box, but with our slight problem with the technology, we lost a couple of questions in there. So please do feel free to put some more into the box. But we have got one question that I think is just worth starting the conversation with. And that is, what are the rehabilitation aids for recovering from brain injury patients? So maybe we should start with perhaps more the psychological aids first, and then talk about maybe some of the practical aids. So I think maybe Zoe and Catherine might be great to start this conversation off. So Zoe, from a psychological perspective, what sort of key aids do you think we can utilise to help people when they've had a brain injury?
Just unmute myself. Well, I mean, that's a very, very broad question. I mean, I think the first thing that I'd always start with is to not underestimate the importance of actually listening and hearing the person's whole story. Because often I think as human beings, and I've had to fight this my whole career, we've got a tendency to want to jump in and fix the problems before we really understand it. And I think one of the most refreshing things in the world is to be able to have a conversation with somebody that really listens to you. And they might not be a fix straight away, but really being heard allows you to connect with that person. And from my experiences, that connection with the therapist, with the nurse, is key for progress moving forwards.
Yeah.
I would say that would be one of the aids for the person. And I think this is obvious, but it's about kind of helping the person achieve the goals that are important to them, not the goals that are important to us.
That's a really good one. That's a really good one, isn't it? Because sometimes as clinicians, we have an idea of what it should look like, and that might not be the lens that other people are looking through. So, and I guess, Zoe, we have to do lots of training to get into that space as professionals, to be able to think in that way. And I would imagine this is where working with people, where nurses can work with psychological therapy experts like you is really beneficial.
I hope so.
I'm absolutely sure of it. So if we go to Catherine now, from a sort of, more physical, perhaps practical, I don't know, because I think communication is incredibly important, but what other aids do you think are quite key from sort of the things that you need to do in order to keep somebody safe and get them on the right track to recover from a brain injury?
I think there are obviously various rehabilitation aids out there that can be used to help people in terms of supporting them at home and doing more therapy at home when they do get home. So there's some work looking at technology that helps with speech problems, with communication, and with memory that could be utilised. There's obviously various wearable devices that could monitor people if they potentially are at home, if they fall, to keep them safe, then it alerts somebody to those kind of things. So there is a lot of technology. I guess there's the robotics and those kind of like technologies to help with upper limb. But I think we're probably at an early stage in some of those technologies and the use of them.
Yes.
In terms of helping people in the rehabilitation process.
Yeah.
I do agree with Zoe in terms of the psychological aspects. I don't think you can get very much better than kind of face-to-face talking with people. And a lot of the work that we've done in terms of psychological adjustment has been using a talk-based therapy called motivational interviewing, which again, I guess reflects a lot of the things that Zoe was saying. It's about trying to be with the person and listen to their concerns, and then I guess the therapist or the nurse helps them to explore in more depth, and helps them to kind of then progress their adjustment and think about how they can overcome the difficulties that they're experiencing. And with that, people generally then tend to come to this sense of acceptance and more confidence and optimism for their future.
Brilliant. Thanks, Liz. I'd like to bring Jenny in now, from the CEO of Same You and your views, but also your lived experience with your daughter about what sort of things would have been the most helpful and indeed were missing, perhaps would be useful to hear.
Thank you. Well, a really inspiring session. I have to say that I am just so thrilled that Nursing Now has put together such incredible people that can really get under the skin about brain injury and to feel as though we can get more insights that we don't have. So what I was really going to offer up as a practical example of what can be done is that we work with University College London, and we were able to fund a small pilot for virtual rehab clinics. And we were asked to see what we could do because of COVID and the lack of ability of therapists to go into people's homes in the community, and the pressures of early discharge of patients after stroke or brain injury. So we've had this running for 6 months. We have no more funding to continue it. But I just wanted to offer it as an example for other people to think about for their own situations in their own countries. And so that's simply using an accepted for your own health service, it could be Zoom, it could be anything like that, it could be Teams, and to get together a group of therapists and nurses and to get people who have left hospital and that need extra support. And you can put together work for rehab, and you can talk about, you can use group therapy. And the big lesson learned is that group therapy has other unknown benefits. So the clinicians hadn't quite realized how wonderful it is for the interplay between each of the patients and who have set up their own communities after this. So very much like Zoe was saying, you know, people can really get going. You start the seed of working together as a community, and then people take it on. So that would be a thing that I would really encourage everybody to talk to UCL and see what they did, and see if you can replicate it.
Thanks, Jenny. Would we be able to perhaps provide a link on our website for people to go in and do that? Is there some materials that we can signpost people?
There isn't at the moment, because they're still involved in it, but I can signpost, and we can signpost to people who can talk to you and to provide those materials offline. Yes.
Brilliant. And Jenny,
can I add something, Lisa?
Yes, please do, Zoe.
In terms of cognitive aids, I think like most of the evidence is really saying that kind of helping people relearn stuff is not particularly useful. It's the compensatory strategies that tend to be more useful. So for example, using things like memory aids. But if I had to recommend and be specific, a slow cooker can be a real lifeline for people with brain injuries, because they struggle with planning and sequencing and organising making meals. And it's not necessarily just for the people that love cooking. It's for people that used to contribute to their families and they lost that role because they can't contribute with the cooking because they might sort of get the timings all wrong. The slow cooker has been great for the people we work with because you can just throw it all in. So that's one aid. Another one is Alexa. Seems to be really good for people, because if you just randomly remember that you need to get milk from the supermarket, you can just tell Alexa anytime you think about it, and then you've got that list when you're in the supermarket, so you're not trying to remember. So functions like that, really. Even when people are a bit disorientated, asking the time and date, which I do very often now we're in lockdown, in Wales still, and Google Calendars is really helpful as a memory aid. So those three things we use all of the time in our service.
Brilliant, Zoe. Again, some really practical examples that can make huge differences to people, and that piece about not trying to remember the past, but pave the path for the way forward. Seems like something that not everybody would initially think, because people want to often go back to the past, don't they? Want it to be like it was, but it's helping them to say, actually, there's a new path to go down now, and we can make it just as good, if not better, moving forward. So thanks so much for those real practical things there. The next question that we've got, and I'm not sure who wants to start this one off, is around the training. What sort of training is there for people that want to work in neurological rehabilitation? So I guess there's both formal and informal training, but who would like to start this? I don't know, Catherine, would you, from a UCLan perspective? And then maybe Zoe with your connections with the university, and then Jenny, I know you've got some thoughts about competencies that we think people should be developing.
I guess in terms of specific courses with formal training, especially with a nursing focus, I don't think there's very many training courses that are available for nurses in terms of neuro rehabilitation, in terms of giving them the practical elements and the competencies and skills maybe that they require. So I think there's quite a lot of things that will increase people's knowledge base, but not maybe increase the practical skills and give them the clinical tools that they need to really implement things in clinical practice. So I think that is something where there is a gap, and we could do more in terms of trying to plug that gap.
Brilliant. Thanks so much. And I think, Jenny, shall we come to you with your kind of the project that you're embarking upon with this?
Yes, that would be great. So we have raised money that we have given to the Royal College of Nursing Foundation. And that's a significant amount of money that will start a integrated neuro rehab training program for nurses and therapists. So it isn't ready to announce, but they are working with the university, and we're building a training. And again, from our patient perspective, what we see is really missing is a graduate module. So you actually understand about nursing. So it's not, it's absolutely somebody who's got some experience needs to try and work on this. But it's how to actually link in the mental health and neuropsychological aspects of rehab with the practical nursing skills. So how do we link brain, body, and mind? And so that training program, we hope, will be ready to pilot in the spring of 2021. And then it would be wonderful to be working with Nursing Now and all of you to see how we can get enrollment of students right around the world to take this really important rehab course.
Fantastic, Jenny, and it's so amazing the work that you're doing. And when we first met, education was right at the heart, actually, of what you were trying to change with some of this stuff. So thanks so very much. I mean, Manashi, from your point of view, what are the key competencies as an early career nurse that you think need to be developed to care well for people that have had a brain injury?
So I think some of the competencies that are really important is being able to look at how to support patients once they're within the home setting. So being able to mainly highlight issues to do with nutrition, how to support families with patient nutrition, how to support families with patient hydration as well. Also mobility. Particularly like with some of the physical effects of brain injury, and how to really support the families with the patient in the home setting with some of those challenges. Yeah.
Fantastic. And I think the thing that's really coming home to me with learning about this agenda more and more, which is such a privilege, is that let's not forget the research competencies, the evidence-based building competencies, because at the end of the day, I think without new evidence, we're not going to change things. So I think that research, evidence, and also innovation and entrepreneurialism. And that's really at the heart, I guess, of what this Global Solution Challenge is all about. And that's why we've called out to the next generation, because I think that often it is the next generation that finds solutions for tomorrow, whilst we're busy trying to find solutions for today. So I think it will be really important when you're thinking about competencies and working within this really rewarding area that we remember they're just as important, because what the power of this morning has showed, I think, to me and many others, is it's thinking outside the box. It's working in non-traditional models that actually yields the best outcomes for people that have had a brain injury. So that's just as important as the other competencies that clearly need to be in place. So I think we've possibly come to the end of the questions and answers now, but I'd just like, given we've got a few minutes, to get some reflections from the panel, if that's okay. So Jenny, could we start with you? Just a few reflections on what you've heard and any more inspirational tips for our solution participants out there that you might have gleaned having heard all with the exciting stuff that we've heard in this last hour and a half.
Well, I think that with everybody on the call, what we've seen is a common thread. And that common thread is everybody taking an entrepreneurial approach. So just as you were saying a minute ago, Lisa, it is about So taking what's already there and then stretching it and seeing how you personally can use your own personal passions and ambitions to make a difference for other people's lives. And so I think with the nurses and midwives who are thinking about taking part in the challenge, I think it is about really, I suppose, looking at their own network and trying to find the Zoes and the Lizes and the Cats amongst them to get inspiration, and then see how they can build on those great ideas and make it their own.
Brilliant. Brilliantly summed up as ever. That's a hard act to follow for the rest of the panel. So Liz, over to you. What's your sort of reflections on the time we've had together this morning?
I think it's very much about thinking about the more holistic about the person, and obviously Zoe's work very much reflects that in terms of not just thinking about the medical model, but thinking about how to really integrate people back into the community, and the importance of those social networks, because again, I think they're really important in terms of people's overall health and well-being. And we do need to think about what we do know about our current evidence base and our practice, and where there are gaps in those evidence base to really think about, as nurses on the ground, you're the best people to actually come up with those ideas, those innovations, and then to get the evidence base behind it to then be able to get more support for what you're doing and get that really integrated into services to help people in the long term.
Brilliant. And Liz, if you're a little bit nervous of doing research or creating evidence base and feel, oh, it's not for me, because we often hear in some countries nurses saying, oh, I'm not clever enough to do research, and of course they are. Any top tips for just getting started on, getting into that space and demonstrating you can do this? Of course you can.
I think so. I know this is very much within our own locality. So within our own locality, we offer clinical internships. So that's getting people to work alongside us on very small aspects of projects. But there's things as nurses that we can do in terms of quality improvement, just looking at, doing, to begin with, maybe doing some audits of aspects of practice that you think might need improving, and then thinking about what is it that we need to do to improve that, and then thinking about then re-evaluating it, and from that point of view, really improving the care that we give to people on the ground. So it doesn't have to be a big multi-centre controlled trial.
Yeah.
You can start in very small aspects of thinking about aspects of care that you think might need improvement, thinking about what you could actually really do to collect some data to try and underpin that, and then think about what you could do to improve that care for patients.
Perfect.
And ultimately involving patients and carers in that process is really important as well, patient voice.
Brilliant, Liz. Thank you for that. Zoe, over to you.
I mean, I guess just picking up on this anxiety about maybe research or going outside of what you think your role is. I mean, I just thought as a personal reflection, it might be quite helpful to share that every step of the journey where I've gone outside of what I got trained to do, or when I've been doing bits of research and others, I've always had the sense that I don't really know what I'm doing. That is, there's never been a sense where I'm sort of, people look at this from the outside and they think you know what you're doing, but I've just had to learn the whole way. So it's just been a steep learning curve. But I think it just comes back to those moments, if you connect with some of the people that you've worked with that have really touched your heart, like I was talking about the guy with the minor lamp, and I just had a kind of awful realization really that our team are the only people that he's got in contact with. If we don't do it, who's going to do it? No one's going to do it. So we may not be the best at everything that we try, but we can give it a go and we can learn and we can get better. I think that's my reflection. And when I was training, somebody said something to me that didn't make any sense at the time. They said, the map is not the territory. And I wondered for ages, like, what does that mean? And I think I understand what that means, that we all get certain training about what we should do when we qualify, but we need to stand back and ask questions about, is this working? The people that we work with and support, they're the ones that know what they need. Like, we need to be listening to them rather than just following that map. So
fantastic. And the final moment, I think, goes to Minashi, who is what this is all about, the next generation of nurses and midwives. No pressure, Minashi, but you've got a couple of minutes to sort of final thoughts from you, and any advice to give to all of those young nurses and midwives out there that are going to submit a really exciting solution to this.
Yeah, sure, definitely. And I think my message would be for, through listening throughout this whole webinar, is for young nurses not to reach out just amongst themselves, but to also think around who else they can be able to involve within their solutions, and how to be able to bring everyone on board towards creating the outcomes that we want to be able to develop. So yeah, I think that would be my message.
Absolutely perfect end to a fantastic hour and a half. So thank you so much to everybody that's joined us and for sticking with our technical glitch. It's been a real privilege to be part of this amazing panel. I'm so proud of us all and everything that we're all striving to achieve. So thank you so very much, and look forward to those global solutions coming our way. We can't wait to read them, judge them, and no doubt make some very tough decisions. Thank you very much, everybody. Bye-bye.